Right. Good afternoon, everyone. Also, good morning to Dr. Nahreen. Today we have Dr. Nahreen Ahmed. She is a US trained intensivist and educator currently based in Philadelphia. She has extensive experience in critical care, medical education, and global health, with particular focus on capacity building and in a resource limited settings. Her work spans clinical excellence, mentorship, and advocacy for equitable healthcare delivery. Dr. Narin, it's an honor to have you here today. Can you start by sharing your journey towards care into medical school, critical care, and global health? What drew you to this path, just for the audience to have some idea?
Yeah. First of all, thank you for having me. I'm so delighted to be here to speak with you guys today. That's it's a very personal question because, being from Bangladesh, I was born in the US, but my parents, they did their training at Dhaka Medical College Hospital, and they're the K-29 batch. And so it was always important for them to take us back to Bangladesh when we were younger, which allowed us to really see the discrepancy in access to healthcare. And for me, at a very young age, that was so obvious, seeing the hallways at Dhaka Medical College, BEMC, being full with patients getting IVs on the floors of the hospital. It's a very stark appearance to a person who grew up in the US, seeing hospitals that we have here, and to realize that the world is such that this is the issue in so many parts of the world where access is extremely challenging and high quality services are very difficult to attain. And so at a young age, I had always known that I wanted to go to medical school. We are a family of doctors, and so I've gotten to see the impact that many of my family members have been able to have through medicine and healthcare, from doctors to nurses to teachers as well. And so that was always important to me and something that many people know, but I'll share here because it's such a big part of my own legacy. My grandfather, my paternal grandfather, Shohi Shamsuddin Ahmed, he was a surgeon in Sylhet who was killed during the Liberation War. He stayed back to take care of his patients, and unfortunately was killed by the Pakistani army. And why this was such an important part of my own personal history is because it also sparked, for me, the need to really advocate for the protection of healthcare workers in conflict, which is a big part of what I do now as well. And so the journey started in medical school. I begged my dad to help me go back to Bangladesh to do a medical school rotation, and with the help of him and some of his colleagues from Dhaka, I was able to do a 1 month rotation at Dhaka Medical. And that was an incredible life-changing experience to be able to be a part of the medical team. The doctors there are incredible. They were amazing teachers, and they really pushed me to think about how you can really do everything how you can go about doing everything you can to do what's right for the patient. Whether they can afford healthcare or not, that's not the issue. It's about doing what's right for the patient, and that's always in the forefront of how we think. I went from then to do residency in Chicago in internal medicine, where I continued to get my master's in public health. And then a very interesting thing happened where I started to learn more about conflict medicine and practicing medicine in very, very limited and difficult to reach areas of the world. And this was something that really intrigued me because I felt that those who are in chronic conflict areas are not thought about. They are not receiving healthcare and high quality services to protect them. And so when I embarked on fellowship, it was around the time that the Rohingya crisis was happening in Bangladesh. I had gone back to do some work at Dhaka Medical introducing critical care ultrasound, which you were a part of, and that was an incredible experience to bring health technology and innovation into the workplace. I was using point of care ultrasound for many years by that point and wanted to introduce it as a part of clinical practice in Bangladesh because I felt that this was a really a great opportunity to bring this kind of technology And it was around that time that the Rohingya crisis was happening, and I had gone out to Cox's Bazar, started working with an NGO called Med Global, and I was with them for about 7 years, working across the globe, from Cox's Bazar to Yemen, to Syria, to Ukraine, to Sudan, and then lastly, most recently, I was in Gaza 3 times since the war started in October. And so, it's a long journey that came with a lot of different experiences. But at the central part of it is Bangladesh, and always has been. And that was really, it started there. The passion for giving back, and that really came from all of the experiences and influences from the Bangladeshi doctors that I worked with, who are incredibly passionate about their patients and healthcare in Bangladesh.
Wonderful, Dr. Nani. It's a very extensive history. I mean, it's a long journey for you. Your grandfather, your father, and you're probably the third generation of doctors
Yeah, that's right.
around,
Yeah.
and traveling through this, like, you've seen the health condition in Bangladesh. You when trained in the United States, you still keep coming back to us, and also you extend to globally. You're right, I was one of the fortunate to meet you in 2017 when you started the critical care ultrasound training in Dhaka Medical College. Can you tell us briefly about what happened at that time? What drove you to that part, and what was your experience?
Yeah. So I think that what essentially drove me to that was that, in my critical care training here, in the US, it was becoming a standard of practice to graduate with competency in the use of ultrasound in critical care. And it became this thing where I couldn't see a patient without having the ultrasound as a part of my physical exam. And then I remember, while I was in training, thinking back to being in Dhaka, being at BEMC, and being frustrated with the other doctors about how challenging it was to even get a portable X-ray done in the ICU. On top of which, patients are very unstable. It's difficult to go to the CAT scan, and this was this image in my head of remembering that access to diagnostic imaging was very challenging in Bangladesh, and specifically in the ICU, and of course in the emergency room as well. And so I pitched the idea to a few colleagues at BMC, and asked, would this be useful? And kind of initiated the conversation by also teaching a little bit about what it is, because at that particular time, point of care ultrasound was relatively early in its understanding across the globe. Many people didn't really understand what it was for, how to apply it, or whether it was a useful technology, given the expense of the machine. And so I embarked on sort of this journey of increasing awareness first of what is ultrasound, what is it used for. Many people just really thought about it as a tool for obstetrics, and really, as and as many people probably here know, it really can be used for any part of the body, and it's such a useful tool, especially when we need to make rapid decisions. And so then I started to look for people who had trained in ultrasound, or who were competent in using it, and we created a team of us that were able to train. And it was truly an interesting experience, because as when you embark on something new, the first response is not usually acceptance; it's usually skepticism. And so there was a lot of skepticism. When I think you said this before we started, if you're really passionate about something, you can make it work. And this was something I was really passionate about. I had saved, and caught multiple things and saved lives in the US and abroad using ultrasound. And I just felt like, this was the prime time to introduce it. Once the doctors really started to realize the power of the innovation itself, I didn't have to do any more convincing. It was very quickly picked up. And the most amazing thing that I think happened was that we taught the very basics of ultrasound, and they would show me and send me pictures of advanced cardiac ultrasound that they were teaching themselves. So the best part was that all we did was open the door. We started, we increased the awareness and the passion to pursue it. And you know what? The best part of it is I was completely irrelevant after maybe 1 or 2 years, which was incredible. that's always the goal, right? When you introduce something, you don't want to be the one to have to push it anymore. You want people to move it forward. And so thankfully to everybody that championed ultrasound in Dhaka, it really made a big impact after that. So I appreciate all of your help with that because I think, it's still an ongoing thing.
Wow, wow. I would say it's an amazing achievement. I mean, you initiated it from the scratch, and then I saw you teaching people how to use the machine and the basic stuff, and then you're saying after 1 or 2 years they become all independent, and you don't need to supervise them anymore. It's amazing. Is this only the Dhaka Medical, or is there somewhere else you trained with ultrasound?
Yeah, a few places. We went to Burnham, and let me see, where else did we go? I think those were the two main ones in. Oh, we went to I think we were at United also.
You did that.
And that's right. And then in Suet as well. Suet is always a place that's close to my heart, and so we did a few sessions in Suet as well. And the idea being at that particular time was that we did not necessarily expect to teach everybody everything they needed to know to use it, but we wanted to say, here, let me show you what exists out there and what is possible here. And I think that was really that was the objective, and we were able to do that. And then people really picked it up on their own, and were able to move it forward. And that to me, I think was the biggest achievement.
All right. Thanks again, Dr. Ryan. I think for the audiences, I'm just gonna quickly summarize. I think we have Dr. Nahreen, who is an critical intensivist, US based in Philadelphia. We've been talking about her journey through her medical career and her work globally, including Bangladesh. Uh, as we have been discussing, that she introduced the first critical care ultrasound in Dhaka Medical College and other hospitals in 2017, which I was a part of. And then I think she's happy after 1 or 2 years they become independent ultrasonogram scanners, and they become really develop the skills. This is amazing stuff. So while we are going to the next question, if anyone have any question, you can just ask or just type in the chat box. We are happy to answer your question because we're going to be covering a lot of topics here today. So since we are on the topic of ultrasound, Narin, so for I don't know if you're aware, there are like roughly around 200 doctors who are currently chasing their career in emergency medicine in UK pathway, which I'm aware because I'm in UK now. So a lot of them, I think they are kind of no ultrasound. I don't know how much they used it. So from emergency medicine point of view or critical care point of view, what are the things they can be used in emergency department? Let's say what should we use ultrasound for in ED?
Yeah, this is a great question. And I think, and I have such a different perspective on it now, having worked in emergency rooms also across the globe where there's a high level of trauma. So, starting with the acute emergencies first, trauma is probably, this is the birth of ultrasound in the emergency room came from trauma and the FAST exam. And I would say this is probably the most commonly used, most easily taught, and easily learned form of ultrasound. And so I would say, using the FAST exam for trauma to identify internal bleeding, how to risk stratify who needs to go to the operating room. This is the base. Like this is the easy bread and butter of emergency medicine. And I think outside of that, then you're thinking about things like, and I always broadly categorize, common things that come into the emergency room: patients with acute hypoxia, patients with hypotension, and in order to identify what is the cause of acute hypoxia, respiratory distress, ultrasound is a great, it can be greatly used for that with the lung ultrasound, with the cardiac ultrasound. There's so much that you can identify very quickly and with equal efficiency of an X-ray, and in fact more quickly because you can do serial exams. With undifferentiated shock, which is another commonly seen thing in the emergency room and in the ICU, really being able to identify the cause of shock is important. And this is again, the FAST exam can be used for that, looking at your IVC, looking at your chest pleura to see if there's hemothorax. There's so many different utilities for ultrasound in the emergency room. And then of course, the big one being, because many emergency rooms also see obstetric emergencies and gynecologic emergencies. That's another one I think that's crucially important, is to be able to identify obstetric emergencies on ultrasound as well. And again, this is a reminder of not necessarily needing to be an expert in the depth of ultrasound, but being able to use it as a screening tool to help you really differentiate your diagnosis. And other things that I kind of group in with acute hypoxia, of course, we think about massive PE. That's another one. You can find characteristics of massive PE. You can do a DVT ultrasound very rapidly and effectively. You can also, and one of the other things that we always teach and keep people on their toes about is pericardial tamponade. These are things that are so easily identifiable on ultrasound and can really help with the critical management of patients that are crashing. And that's what I kind of think about with ultrasound is I think about how it can help you rapidly differentiate diagnoses in an acute emergency, taking a step, down from the acute level, like level one emergencies. Then you're thinking about things like, cellulitis, like infections, fluid collections and things like that. Talking about looking at neck anatomy, that's another easy one. These are things that are sort of maybe not necessarily a full acute emergency, but these are things that come into the emergency room and sort of you can also utilize ultrasound in that scenario as well. And so I think that's probably where I would start as sort of the way to categorize and think about ultrasound.
Wow. It's a huge number of topics. I mean, a huge number of scenarios that actually ultrasound can help us to early decision making and diagnosis. And I'm amazing because you started this training in Bangladesh in 2017. I believe so far there have been a lot of improvement. However, but again, it's not across the Bangladesh yet, but it's still something to start with. And I'm happy that you did mention the start of ultrasound being the first scan and trauma, and also it can expand. You can expand this to cause of hypoxia, undifferentiated hypotension, shock, and the other aspects as well. Also, I think you did in that 2017 you did also taught people on DVT scans, those things, cardiac ultrasound and DVT scans. And also, I think in day-to-day practice, also we do use ultrasound for difficult IV access, central lung.
Yeah, yeah,
Yeah. So in
yeah.
this scenario, I mean, I'm sure you have a lot of experience in this side, but can you give us some examples, like real life situation that you can share with the audience, that interesting case or anything that ultrasound really helped to make you a difference?
Yeah, I mean, I think for me, working in the ICU, because patients are often so unstable, it's very hard to move them. Probably the most practical. Let's see, I was just working last week in the ICU, and we had a patient with severe acute hypoxia. It happened rather rapidly. They were the patient, rather obese patient, so very heavy chest wall. And so we were requiring, she was on the ventilator, we were requiring a very high amount of PEEP in order to recruit for alveoli. And what happened was that all of a sudden, on a PEEP of 20, which mind you is very high, but her plateau pressures were still stable, she all of a sudden became acutely hypoxic. Now, of course, the first thing I thought of was the pneumothorax. And because with that degree of PEEP, and so she was also becoming hypotensive, which simultaneously she was receiving sedation, but at the same time, you have to rule it out. So I took the ultrasound, quickly put it on her anterior chest wall, looking for lung sliding. And thankfully, there was lung sliding on both sides. This is something that we taught in our class too, which is that, you kind of also need to understand the limitations of ultrasound. So I first used the linear probe because generally speaking, you can see the pleural line a little bit better with that. Unfortunately, because of the amount of soft tissue, the depth of the linear probe is only about 6 centimeters, 6.5 centimeters. So I needed actually more than that. So because I initially couldn't see anything, I thought, oh my gosh, maybe there is no lung sliding, but I couldn't actually see the pleural line. So I switched to the phased array probe. And as you know, you can get more depth with that given the lower frequency. And I was able to see the very clearly lung sliding all across the chest wall on the right and the left. And so this was like probably this is the most recent and practical example where, and the interesting thing is, as this was happening, I grabbed the ultrasound and somebody called the chest x-ray, called for the x-ray tech. The x-ray tech took 20 minutes to come to the bedside. And by then, I already knew what was wrong or what wasn't wrong, and we figured it out. So by the time the X-ray tech came, I apologized. I'm really sorry. We actually don't need you. We're okay. And I think for me that wasn't just a real life example, very recent. That just highlights the critical importance of ultrasound because of how fast it is. It's right at your fingertips, and you can get it much more quickly than even the X-ray. So and it turns out that all that happened actually was that she was coughing, she de-recruited, and that was basically the cause of that. She auto peaked a little bit, and her blood pressure dropped because of that. So we were able to sort that out by using the ultrasound.
Wow, wow. And this is interesting. They said linear probe, Silang sliding, and then he changed the probe, and then the depth was the issue anyway. So these are the interesting things. I think a lot of people probably would be interested to know anyway. So emergency department or eye critical care is ultrasound is the go to, and by the time the X-ray tech is coming, it's half an hour is probably is too late. Or anyway, that's one good example. Can you give us another example? I'm just asking in terms of, let's say, if someone is short of breath, you're considering PE, what would you be looking for with how ultrasound would help you to differentiate PE or not?
Yeah, so this is a common thing. This actually did happen recently, earlier last week, where I had a patient who was to too unstable to go to the CT scanner to assess for PE. And so what we did was we were trying to figure out our threshold of whether, risk stratify whether or not this person actually does have a PE. What we ended up doing at that point is we did a cardiac ultrasound first, and noticed that she had a normal appearing right ventricle, which does not rule out a PE, but it does probably rule out a massive PE that's causing right heart strain. And then we went looking for a DVT because, as we know, commonly lower extremity DVTs, especially in the ICU, are usually the cause of PEs in our hypoxic patients. And you know what? Sure enough, we found the lower extremity DVT. So from then, the threshold of does this person have a PE? If I don't need to see the CAT scan, I'm going to anticoagulate because there's going to be a risk of PE if it hasn't happened already, because they already have a proximal lower extremity DVT, and my threshold to consider acute PE was much higher. And so I didn't have to send the patient to the scanner immediately. Eventually, when we stabilized them, sure enough, they did have a moderate sized PE, but again, not a PE that was the cause of their hemodynamic compromise. That was due to sepsis, but a PE that was probably worsening their degree of hypoxia. So that was a real life example of how we were able to kind of make a best educated guess that this person had a PE. Now, in that scenario, I had also thought about, what if I didn't see a DVT? Would I, if a DVT entirely lodges up towards the lung, like, you're not going to necessarily see the evidence of a clot in the leg. And in those scenarios, that's where we recognize that, okay, the ultrasound has a limitation because it can only see so much. And at this point, you have to make your clinical judgment. And I think at that particular time, with a low risk to start anticoagulation, I would have just done it, because until we gather more information, better to treat if there is a low risk of complications from that particular intervention. So that was and I make that point because I think in the age of ultrasound, so many people grab it before they even put the stethoscope on the chest. And so, I'm the first one to grab an ultrasound, but I will also take a listen with my stethoscope and do my clinical exam, and have to use my clinical judgment alongside with the information that we have.
That is a really interesting case. So even though you don't see typical D signs or right ventricular
Mhm.
uh, um, um, sorry, like dilatation anyway. But even the patient, you're clinically suspicious, the patient has DVT, you don't need to actually, wait for a diagnosis. You can start the treatment. Is that so? That patient was unstable, you said, or a stable
Yeah,
patient?
they were hemodynamically unstable, and that's why what I was trying to understand is the size of this possible PE so big that it's causing the hemodynamic compromise of the patient, because I would have potentially considered giving TPA. If they're hemodynamically unstable from a PE, that certainly is a consideration. the need to do that to stabilize the patient. And so, but it turns out, because our patients are often complicated and have more than one problem, this patient had a PE and also had sepsis from a bacteremia. And so their hemodynamic compromise, once the cultures came back, was really because they had a septic source, and then concomitantly had a PE, which is often the case in our patients because they're so critically ill. And the hospital I work in is a major cancer hospital as well, and so they had a background of cancer. So put all these things together. If I give you all of the clinical information, the story for a massive PE was there. But then as we gathered more information, the story for sepsis complicated by a PE, a moderate sized PE was the more likely story.
Yeah, that's interesting case. Wow. So I'm going to move on to another topic on ultrasound, which is a tricky situation, tricky case. But in your experience, have you used ultrasound in situation for query dissection, aortic dissection, and have
Yeah,
you?
I've used it to assess for aortic dissection. If we have, especially we have so many patients that come in hypertensive emergency, back pain, all of these things, kind of the symptomatology that you hear about in the textbook. And so it's such an easy thing to do to put the abdominal, the curvilinear probe on the abdomen or even the phased array probe and to look for aortic dissection. And so, and even you can do a suprasternal view as well to look for more proximal dissections. And so it's always one of those things where it's such an easy thing to do. Why wouldn't you do it? Kind of that's how I look at it. So many people ask, well, I don't think that's on my differential. And I said, well, you have the machine. It's very easy. It's not a risk to the patient to look. And it's one thing you can cross off your list. And it's important to kind of to be able to think about that. So yes, definitely have used it. Probably a little less common in the ICU, but definitely very commonly seen in the emergency room. And it's used quite often in the emergency room for this reason. Aortic aneurysms and dissections are often easily evaluated in the emergency room.
And just for the audience to clarify, don't if just to let them clarify this situation. So in dissection in ultrasound, you're looking for a dissecting flap. Is it something you
That's
look?
right. Yeah, that's right. Yeah. Yeah, and it's often hard to talk about these things without the images. And so I would definitely, urge people to look at, there are so many great free resources out there. 5 Minute Sono is probably one of my favorite. And that really give you some quick techniques on how to use the ultrasound to identify the pathology and then what the pathology looks like. But yeah, you're basically looking for the dissection flap. That's right.
I see. And at the same time, so if it is a type A dissection, dissecting
Mm-hmm.
into the cardiac, and what do you expect in the cardiac ultrasound if the patient is, let's say, tachycardic, hypotensive, and you're considering type A dissection, what would you expect in the cardiac ultrasound?
Yeah, so this is if your suspicion is high enough, you'll see a pericardial tamponade in that situation. And so definitely looking for that. And then, proximally, you can kind of see a little bit of the aortic arch if you're looking above the notch. And so, so you can, in some instances, see the dissection flap in that case as well. And so those would be sort of the two things I would be looking for.
Interesting. Thank you so much. Again, you did mention about like a bit of musculoskeletal issues like cellular
Mhm.
access. Do you use them to differentiate? What are the
Yeah, pretty often. Yeah.
muscle?
Yeah, pretty often. I mean, it's one of those things where, so unfortunately, there's a very big drug epidemic in the U.S. right now. And one of the most common things that people are coming into the hospital with is withdrawal from opiates. It's and Philadelphia, unfortunately, has one of the highest rates of this. And so, and many patients end up in the ICU because of the severity of their withdrawal. I mention this because the drugs that are being used actually create an ischemic effect in the limbs where there is tissue damage and people are coming in with wounds, skin wounds. And so I do often, and because it's very hard to tell sometimes if these wounds are actively infected or chronically infected, I often do use the ultrasound to see if there is, cobblestoning, which is basically edema of the soft tissue, which indicates, inflammation, infection, swelling, versus a fluid collection, which might, indicate a need for drainage. And so I will often use it for that. And then, on top of which, we have patients that in the ICU, especially that, maybe 1 week into their admission are all of a sudden having a fever and you don't know where it's coming from. And so when you do a full skin exam and things like that, maybe it's a infected line or infected location with previous IV or something like that. What's great is that you can just put the ultrasound on the limbs where you see, erythema and see if there's anything that would be the indication for the fever. And so I do often use it
Yep.
in those scenarios. Yeah.
Yeah, that's interesting. I think there's so many things. I'll probably running out of time to discuss all of this. And I think recently, in our department, they're trying to use ultrasound in terms of like bladder volume assessment. So, you have the bladder scanner, but the bladder scanner is somewhere, found to be nowhere. Sometimes we struggle to find the bladder scanner, but ultrasound is a very good tool to assess the urinary bladder volume. Is it something you use there, or is
Yeah, very often actually, because for two reasons. One, the other thing about the bladder scanner that is problematic is that it cannot differentiate between urine and ascites. So if you have somebody with pelvic ascites or abdominal ascites, it will often tell you that the bladder volume is like 300, and then if you actually put the Foley in and you see the Foley balloon in the bladder and nothing comes out, and you're wondering why, it's because they probably have ascites. The nice thing about the ultrasound is you can actually see the ascites. You as the viewer can differentiate between ascites and bladder volume or urine. And so we do often use this because just like this would happen on the general ward in the ICU, anybody with a Foley, if all of a sudden there's an abrupt drop in urine output, the easiest thing to do is one, assess Foley placement, or if there is no Foley, then to see if there's urine in the bladder, to see if there's obstruction. I usually, when I'm using ultrasound in the abdomen, when it comes specifically to the GU tract, I always try and remind people that you don't want to just look at the bladder, you want to also look at the kidneys. It's the whole system that's connected. And so, to understand if there is hydronephrosis, because this happens, that you might have abrupt drop in your urinary output, and perhaps there's bilateral hydro, something like that, or a stone. And these are things that you can help narrow down with ultrasound. And so I use it very frequently, often just for Foley placement, or if there's an abrupt or change in the urinary output, then we use it for that as well.
Since you mentioned abdominal ultrasound, what else we can do in ED?
Gallbladder is probably one of the most common, easily looked at. It can be a little bit challenging when you're learning how to do it, but it's probably one of the most priceless parts of the abdominal exam, especially in the emergency room. It's so common that you see people come in with abdominal pain, right upper quadrant pain, and so differentiating between liver versus gallbladder. I've even taught liver mets on ultrasound of when looking at the gallbladder, and so it's important. The hepatobiliary system on ultrasound, I think, is a really crucial thing to be able to look at. And you're looking for pericholecystic fluid, common bile duct dilation, things that are pretty easy to find, and your Murphy sign while you're doing your exam. And so I think all of those that's pretty crucial. In certain instances, you can even see perforation if you see the absence of sort of gut sliding is what it's referred to. I'll be honest, I think that's one of the more challenging ones. You can see when you have a small bowel obstruction, you can kind of see, bowel contents kind of swishing back and forth and dilation of bowel on the ultrasound even. And then of course the usual things, you can look for ascites and things like that, which is important. If somebody comes in with abdominal distension, looking for what the liver looks like. A cirrhotic liver is very obvious on ultrasound, and looking for ascites and trying to identify those things as well. And then of course, speaking of ascites, and I think you mentioned this a little bit earlier on, but in the emergency room and in the ICU, both procedures are made safer by ultrasound. And so, if you do find ascites, you can do an ultrasound guided paracentesis, you can do thoracenteses, and I trained in an era where we did not initially have ultrasound, and then we had ultrasound. So I was doing thoracenteses and paracenteses without ultrasound at one point. And when I think about that now, it terrifies me in retrospect because you don't know where the needle's going. And you don't know where the biggest pocket of fluid is. It's sort of like a guess almost with your clinical exam.
And then actually in Bangladesh is still without the ultrasound in most of
Yeah,
the,
yeah, yeah,
isn't it?
yeah.
I'm great that you mentioned gallbladder. I mean, actually, I think yesterday I diagnosed one cholecystitis with ultrasound using ultrasound in right upper quadrant. It's very handy and useful in avoiding CT scans and everything else and surgical pushback. You know what I mean? Anyway, so abdomen is a very great place. One other question I was thinking, which I haven't used it, but I know if you haven't used, are we like in terms of AD skill set, are we able to say appendicitis or no appendicitis with ultrasound, or is it something we need to work on?
I think in children, yes. I think in adults, it's really challenging. And same thing for like pancreatic head mass and things like that, which, if you're really good and you have a thin patient, you might be able to see that. But I think historically a bit challenging. I think it's a body habitus thing. It is also, the operator,
Yeah, yeah,
extremely operator dependent, and I think it's often challenging. Yeah.
yeah.
But I mean, I will tell you, very relevant to Bangladesh. There are, I just wrote a chapter for the butterfly ultrasound group for using ultrasound for dengue and identifying high-risk dengue patients who are at risk for developing dengue hemorrhagic fever and shock. And because, as it turns out, you see capillary leak in the form of pericholecystic fluid, which is one of the most common findings, pleural effusions, ascites, and things like that. And so, and B lines on ultrasound if you're looking for pulmonary edema. And these signs often predate the hypotension by like a day.
Wow.
And so you can, if you are screening patients, you can identify these characteristics and identify high risk patients early, which imagine, with dengue and the mortality rate in Bangladesh, because it's usually, from complications, not from shock and not being able to have access to blood products and things like that. And if you can identify those patients early on, you can transfer them to a higher level of care. So these are also, ultrasound. All the things we're talking about are sort of like established in ultrasound. And what's really interesting is we're moving into an era where people are discovering the use of ultrasound in screening and risk stratification in ways that we never thought about before. And I think that to me is like is brilliant, and that's where I think things are going. There's studies on using ultrasound for tuberculosis and extrapulmonary and pulmonary tuberculosis, and I think as we move forward in the era of technology, we're going to see so much more uses of ultrasound, and then of course AI, which is a whole different conversation. But
Yeah, yeah. I mean, really interesting. I never heard of this screening part of the dengue hemorrhage where you can actually, predict the deteriorating patients based on. Would you be able to
yeah,
send us some links or some
yeah, for sure, yeah.
for the audiences or share to the group so none of us would know?
Yeah, I have yeah, for sure. I have a lot of literature on that, so I can send that over to you. And it's I want to say the original study was in India with children, and then it was extended beyond that, and there have been multiple reviews of much of the literature, and it's relatively good. I mean, right now there's a study happening in Peru that is validating validating this, but it's the again, it's sort of one of those things where it can be incredibly useful in sort of that risk stratification and transfer because the majority of the world suffers from the lack of access to specialized care, and whether that's ICU care, surgical care, blood bank, like these, and even I'll say even in the U.S., it's not even just abroad, but even in the U.S. right now with the state of healthcare, I mean, there are parts of the country that don't have access to to things like that and transferring very sick patients, when at an appropriate time that you can provide life-saving treatment is a huge role that ultrasound is, I think, playing.
Yeah. Naren, I will change the topic now. So we have
Sure.
like 20 minutes. I think there are other things to cover here as well. So obviously, if I think we may have to re-invite you again for a specific topic on ultrasound for a bit detail inside. Is it okay?
Yeah, sure.
Right. So moving away from this side. So general question. So you've been in touch with Bangladesh all your life. And also, of course, the medical, the emergency medicine and EMS. What do you think the gaps in Bangladesh, from your point of view? What are the gaps in Bangladesh in emergency healthcare? What do you think?
So, um, you know, I, that's a that's a very complicated question to answer, but I'll give you the short answer first. I think, you know, unpopular opinion, but I think it starts with leadership. The probably the biggest gap is that there is not a clear leadership in emergency medicine. There are a lot of leaders,
Mm.
and some incredible doctors who have done so much to attempt to bring emergency medicine to the forefront. But the issue is that there's no clear leadership, and what often happens. It's not just a problem in Bangladesh; it's everywhere. But the infighting that happens because of ego and politics, and
Yeah.
unfortunately, that becomes a huge problem. And for me, it's an unacceptable problem because patient care should come first. And this is lives we're talking about, vulnerable people who are not able to receive the care that they need because of ego and politics. And this is a worldwide problem, so it's not just Bangladesh. But that I believe is problem number one. And I think outside of that, it's the emergency medicine is new across the globe. Honestly, it's an unfortunate thing, but it's true. And when we talk about emergency medicine, the first thing I think we have to focus on is the gap of triage. When we talk about how do we provide acute care and emergency care, is identifying the sickest people first. This always has to be in the forefront. Is how do you identify the person that will die the soonest is who you have to get to first. So, I think, that's probably problem number two is that we're not seeing a robust triage system. And, the third thing is I think once you triage this idea of the golden hour, whether it's the golden hour for sepsis or MI or whatever it is, every minute counts when it comes to a sick and critically ill patient. And so starting the antibiotics early or, starting the heparin early or, Plavix loading, whatever it is, there is a time sensitive intervention that needs to happen. What I often see is that those time sensitive interventions are often pushed off to the ICU, to the general ward. And so they're not happening where they should be, which is in the ER. The ER is not meant to be a place where you only triage. It's a place where you triage and then provide care in that 1 to 2 hours of critical time, because that does make the difference between life and death, or mortality and morbidity. And so I think those are probably the three things that I would broad categorically say are some of the issues. The hopeful thing is that this is there is a revolution happening in Bangladesh in broad, right? It's this idea that the country deserves better, and people are motivated, and I think that is probably to me the biggest hope is that this is the moment. If we're going to introduce something that can revolutionize the healthcare system, now is the time because people are motivated. They want to see the Bangladeshi people receiving better care. People don't want to have to go to India and Singapore, and this is like I think this is the moment. And so while there are a lot of gaps, I think there is a lot of expertise. There is a lot of motivation. There are a lot of really good people in Bangladesh that can make this happen. It's just a matter of organizing.
Excellent. I think I really like your idea that you said the first is lack of appropriate leadership. Is I agree with you completely because even though we do have experts, all levels, but we don't have the leadership to move things forward. And I feel the same way. And I think we are struggling. And it's a problem globally. It's not just Bangladesh. Um, the other things I completely agree with you. All this golden hour and time critical management that's not been happening. However, we don't obviously, as you know, we don't have the infrastructure or the trained doctors. So things, all this, these are the things. First thing. However, good news is today somebody sent me a message. I mean, a Facebook post that I think the BSME, Bangladesh Medical University, BSME or PG Hospital, I think they started. They're actually they started emergency medicine as a specialty, something like that. I just heard that today. So I think if that happens, at least something I would say something to start with, something that is being recognized in Bangladesh now. Obviously, we don't have pre-hospital. That's another big gap, isn't it? We
Yeah.
don't 911 or we don't have any emergency call that doesn't there's no ambulance service, there's nothing. So in July revolution last year, I mean, whenever I saw in the news that people are they're transported to the hospital and then they declared dead, I'm like, you know they're dead on the way to the hospital, by the time,
Yeah.
even in the hospital, how many trained staff, how much infrastructure we have. So those are the things that actually make me feel sad because I know there could have been a lot of preventable deaths
Mhm.
in those scenarios. And as an emergency physician staying in UK, I don't feel like I'm being used in Bangladesh. I think a lot of us needs to actually physically move to Bangladesh. I'm keen to move to Bangladesh. I think a lot of the audiences know here, and then I see what I can do. But it's not like one person job. Of course, it's a matter of leadership and also a lot of policy making issues. That's one
Yeah.
very important topics here. And the other things, since we're talking about gaps, I think Naren, you did try to create a certificate program in Bangladesh
Mhm.
around the COVID time. I was initially involved. Can you tell us briefly how did it start and what happened?
Yeah. So, the certificate for, so my place of work in the US is at University of Pennsylvania, where we have a very robust global health emergency medicine program. And this certificate program was already ongoing in Pakistan. And so I approached the lead of that program and I said, I would love to see this in Bangladesh. And there was a lot of excitement around it. It moved very far, thanks to Dr. Tablu, who was like a very, very pivotal in moving that entire project forward. All thanks goes to him for everything I've done in Bangladesh has been because of him. And so I think what really happened at the time was that we were hoping that there was going to be more of a governmental recognition of an emergency medicine program. That was sort of the idea. We started with a certificate program. If this goes well, that this becomes a legitimized fellowship or residency program, and then there will be actual emergency medicine positions in Bangladesh, so that people can fill them once they graduate from that type of a residency. That is where everything got halted. It was the politics of behind kind of formalizing it, and to no fault of anyone other than like this was just what was happening at the time from a government perspective, that there just was not enough support and backing to move this forward despite the need for it. The other part of it that was really challenging was that, and look, I understand this part, but the certificate program, the Penn leadership had wanted to combine the programs for Pakistan and Bangladesh. Now, for obvious reasons and historical reasons, this was a very challenging thing to accept, and so that was the crux of why it wasn't successful. And so, what's really hard for me is that I am also historically tied to the geopolitical conflict that occurred, right? So this is obviously very personal, but I also recognize the need to move forward and figure out a way to fix our country's healthcare system, and but it has to be done from the inside, from Bangladesh. And so what I learned was two things: that even though Bangladesh and those who were involved in this did not necessarily want to pair themselves to Pakistan, understandably, I get it, and the generation that is in charge of this is even closer to what happened, and so I cannot discount that. But I think what that also means is that we have to, we have to become self-reliant completely. And in order to do that, and in order to move that program forward, we needed people that were championing it to want to do it, whether the program existed through Penn or not. And that is where, for me, that was the problem. I think there was not enough motivation for somebody in Bangladesh to take it forward with enough leadership backing in Bangladesh. I think you going back is great. Me doing something, and I've always kind of stood by this, is that I want to be as helpful as possible, but my role is always going to be at the training side. From leadership in moving the program forward, it can never be from me. I live in the U.S., so it's not right. It should come from the Bangladeshi doctors in Bangladesh who want to move it forward, who can champion it, who are there on a day-to-day basis. And I think that's why it failed, because we did not have the level of support we needed, and really had to be led by somebody in Bangladesh.
Nice, thanks. I mean, I was really, really, initially I was really excited and I was really happy that something's being happened. Even though I was a little bit sad because I wasn't in Bangladesh, I wasn't physically there to help
Yeah.
you. But then later on, when it's like didn't work, I was a bit upset. But anyway, now I understand it's like it's not just you, it's just other, leadership and other things happen.
Yeah, and it's a combination. It's always going to, like I was saying before, I think about, at the time I was frustrated, and I wanted to blame so many people, but then I had to take a minute and say, there is no use in pointing fingers. It's not productive. It cannot move us forward. And I think what we really need to do is reflect on why it didn't work, and not because of individuals, but because of a systems problem. And we need to fix the systems. And if we don't fix the systems, then we can't move forward. And so that, to me, was the biggest lesson. Is I had to take a minute and say, okay, I know you're angry and upset about this, but the big thing is that it has to be a systems approach, and it's not about any one particular individual. It's about changing the system.
And yeah, I completely agree with you. And more or less, I'm kind of similar position like you. Sometimes I feel like I want to do a lot of things, but I have a lot of like other obstacles like policy making or bureaucracy, a lot of things that stops us actually knowing that I am keen to do it, but the system doesn't allow me to do it. Anyways, I think we still, I would still say keep pushing. I would say keep going. I would never stop until I try my best or keep trying anyway. But thanks, Nine, for everything you've been doing. I really appreciate, since I didn't know a lot about you until 2017 or until now. But I really appreciate that you've been being in, US born, and juggling between Bangladesh and US is not an easy job. Not too many people are doing it. And the thing is, the motivation behind you is amazing, and that's how keep you going. That brings us to the next question. Two question actually. First of all, are you still doing actively anything in Bangladesh, or are you doing something you call Med Global? What exactly you're doing now?
Yeah. So right now, these days, the work in Bangladesh is a little bit less. I was working with BRAC for a short period of time, consulting with them. And then, one of the newer things that happened is my family, is, in conjunction with the Kidney Foundation, built a hospital in Suez. And so that's the Suez Kidney Foundation Hospital in Suez, which, as a family and as a healthcare worker from of Bangladeshi origin, I'm extremely proud of the work that went into that, and that is all. I take zero credit. That was my father and his passion, father and mother both, really pushing that forward with their counterparts in Bangladesh, and so I'm sort of kind of leaving myself open to kind of help with that whenever needed. But what I realized about work in Bangladesh was that I am always going to be here for when there's a need. But I have not been as active, I would say, in Bangladesh in the last year, mostly because the majority of my time and efforts have been going into a lot more of the war zone work. And so I was with Med Global. I'm currently working as a consultant for the Gates Foundation. We have a project in Yemen. And then I work intermittently with an organization called UK Med. That's why I was in Gaza with in October and November for 8 weeks. And then the 2 trips before that were with Med Global. And so the majority of the work I'm doing now is mostly war zone work. And so that pulls me away from Bangladesh a little bit, but I'm always kind of connected and there when needed.
Now, just to clarify, where is this kidney foundation? Where is it?
It's in Suet. It's in Suet, and its exact location that I wouldn't be able to say, but it's in Suet. It's sort of like maybe 20 minutes outside of like the main Suet city, and it's a rather large hospital now, and it's relatively new. And actually, it's an opportunity, given that there's an emergency room there, for us to, on a microcosm, really work on a model for emergency medicine, and that is what the hospital leadership is gearing to do, which is create the emergency room in such a way that it works like a modern emergency room, meaning that there is a triage area, that they're managing patients down there and not just triaging. And so, having seen it, I'm really impressed by what and they're now talking about getting an ultrasound to make sure that they have that equipped. I think it's a wonderful way to look at the fact that in Bangladesh, this is a sort of different answer to a different question, but in Bangladesh there's a system of public hospitals, there's a system of private hospitals, and Field Kidney Foundation is a hospital that also received support from the government, and which is great, but it also has the ability to kind of function on its own. And so what I think is great about that is that you can create successful models in a private model, in a private system. And if that model, and if you have buy-in from the government and those that are going to create the policy change, you can kind of exemplify what you want something to look like without having the government buy-in, and then kind of transition it. And those are, it's one pathway towards considering how you can change the system, is by exemplifying it somewhere where you have a little bit of control to do that. And then to, bring in stakeholders that can say, hey, this is actually a really good idea. We should put this in a public hospital setting.
This is amazing example. I mean, amazing. So you said that they're actually having an immersive department in the foundation and probably having also. So this is, I'm assuming this is like a full-fledged hospital covering all the special.
Yep,
Oh,
that's
wow.
right. Yeah.
That
Yeah.
kind
Right now it's a bit limited because it's just open. So they're still they're going phase by phase. And right now they are, because the primary idea of the hospital was actually to provide dialysis at a very low cost, to patients, because as many people know, dialysis is not, something that normal, working class people have access to in Bangladesh. And so that is, something that the foundation is trying to change completely, because this is a life-saving treatment. On top of that, there are ward floors, and there's an ICU and all of that. So they are sort of slowly opening the hospital so that they can ensure that all the services are high quality, rather than opening everything at the same time. So, which I think is great, because they're taking in, doing all the necessary research and information gathering to make sure that it's a fully functional hospital. But the emergency room aspect of it, I believe they started as an urgent care, just to kind of scale up a little bit, and then eventually we'll be accepting more. But yeah, no, in their mind is ensuring that there is like a resuscitation bay, and that there are that the flow of the emergency room is meant to mimic the flow of a proper emergency room. And so I think that to me was sort of step one, is we shouldn't have to build a hospital to create that, but it does show the need to recognize that emergency medicine is not just the training part, it's also the infrastructure, and it's the infrastructure behind how you model the room, and how you set up the resuscitation bay, and how you have your procedure room, and like all of these things that are crucially important to how you create an emergency room. And so I'm excited about that, and I hope to have more involvement as it grows.
and I believe they also have critical care, CCU and ICU. Wow.
Yeah, that's right. Yeah.
Can I join there? I'm just
I'm sure they'd be happy to have you.
like, I'm amazing.
It is beautiful, so obviously, if you're willing to move there, I'm sure they would be happy to have you. But even more so, when you do get to Bangladesh, I imagine having your background in emergency medicine training and you coming and training or overseeing, that's something, the need I imagine will be there. And I think, it would be a wonderful opportunity at that time. So yeah, definitely stay in touch when you get back to Bangladesh because that I imagine that will be a great use of your time for us.
That's a good. Now I have a plan B anyway. Thank you so much. I mean, this is amazing things. I mean, this is the something recently, if you ask me, I've been back in my mind, I was thinking, why can't we build an hospital, not a government hospital, something semi-private or some private hospitals that actually we can create from ground on and see how it goes, and including emergency department. I think this is something you already doing there as a kidney foundation, which is amazing. I really like it. It's a really lovely idea. I think there should be more similar should be opening up. If that's one successful, you can actually take it as a role model and just duplicate. Sometimes
Yeah, exactly.
sometimes I think, and if you have a role model hospital, like the way Dr. Yunus, replicate the Grameen Bank,
Hmm.
he say, ask them, oh, come and, learn from us and just duplicate on your own place, isn't it? So that would, in that way, at the long term, to be honest with you, long term. So I think we all would want this emergency medicine service at the remote village level. So
Hmm.
even in the remote village, they should have a basic emergency care, which doesn't exist.
Yeah.
So if we can achieve that at some point in our lifetime, I would share that would be enough. If we can,
Yeah, I agree. I mean, the thing about Bangladesh is that I don't know if many people know this outside of Bangladesh, but Bangladesh has one of the most genius in health infrastructure in place. It's just not functional. It's you have community clinics in every district at every level where walking distance,
yeah,
somebody can go to a community clinic in Bangladesh. And so the problem is that many of these community clinics are not kept up. The government is not, there just wasn't enough money to support them in a big way. And but there is a structure that exists in every single area of Bangladesh. Maybe and I've seen so many of them. And the thing that I find so interesting is this is a unique opportunity for the government to scale up this idea that was so smart of somebody to do to provide an access to healthcare that is literally walking distance from any village that
yeah,
everybody can access. Right? That was the idea that there's so many millions of people in Bangladesh that are living across the country, from villages to cities, and they need access to care. The problem is that it's such a gargantuan thing that the upkeep for it is really expensive. And so, I think, and this is something I think BRAC was also trying to do, which was to create a model of these community clinics on how it can be successful. And of course, one of the big objectives being improving maternal child care. But if you think about that, that's also basic emergency care is something that is easily you know
right.
implemented in these community clinics. And so I think there is a lot of opportunity for the Ministry of Health in Bangladesh to make a difference because the structure is there. I mean, if you look at most parts of the US, we don't have that kind of structure. So Bangladesh is already ahead in that sense
Yeah.
that somebody had this idea, they put the infrastructure in place, but the infrastructure just was not kept up. And so that I think is a really important thing. And I hope that the government of Bangladesh in the near future continues to increase and improve the resources that are available in these community clinics.
I understand. And completely agree with you. We are underutilizing our resources, which already have the infrastructure and everything. And although in terms of, I think some of us, one of us or some of us needs to take the initiative to create an ideal role model community clinic just for others to replicate it. Somebody needs to take this. I don't from the government. I mean, actually, you need to push the government. Government doesn't.
Mm-hmm.
I don't think they think about emergency care unless they're being pushed. The other thing I'm really recently aware that there's a lack of like public awareness of
Mm-hmm.
what emergency medicine should look like. Lack of general public awareness. Nobody knows whether they need to know CPR or not. There's lack of CPR trainings, or even in US. I think you guys are trained like high school kids in CPR or something. In
Mm-hmm.
Bangladesh, doctors doesn't know how to. Some doctors doesn't know how to do CPR properly. So I think it's a lack of general awareness that is needs to be focused. I think that needs to be prioritized. I think there's sometimes I was thinking whether we could have like done some like a free camping and other things in every villages just to make them interested and teach them how to do CPR, BLS, those things. Like in anyway, I think once there are multiple things can happen. One is the general public awareness, and then this is like creating role models for others can follow, and pushing the government to do something and to help the system moving forward. Anyway,
Yeah,
now
and the one thing I think I'll add to that is that Bangladesh has always been a model of the power of the community, and the power of the people. And I think something that always stood out to me is the idea of community-based interventions. And BRAC did this, Friends in FIDVB did this, Grameen I think did this as well. But this idea that if you teach people the basics of their own healthcare, they're interested, they're motivated, they want to survive, they don't want to die of chronic disease. Nobody wants that. And people are willing to learn and they're interested. I actually did a study with women in villages, remote villages in Bangladesh, where we asked them, what do you want to know about your own health? And you know what they listed? They listed the top three, without even knowing, they listed the top three causes of death for women as their area of interest. They wanted to know more about breast cancer. They wanted to know about cervical cancer. And these are, in some instances taboo, but they wanted to learn more about their body and their health and why women are dying. And then they wanted to learn about mental health. And I thought this was a remarkable thing, because if you teach people and raise public awareness on certain things, especially mothers, by the way, the matriarchs of the family, they will teach others. That's just how this works. And this ability to start with the public awareness of just health.
yeah,
If we really go back to the basics, it's about training people to understand what their health is and what being unhealthy is, and talking about nutrition and talking about the things that plague so many of the Bangladeshi people, which is diabetes and chronic kidney disease and high blood pressure and high cholesterol. And it's just teaching people about health. And I think everything starts there. It's the most basic community intervention of raising awareness about primary care. And I think, that's really that I think is the crux of this, is that the community can be such a big part of this, and such a huge collaboration between health workers and the community. I think that's really where it starts.
and I agree. I always feel that we need doctor units in healthcare. Just to do something like Grameen Bank,
Yeah.
primary care and emergency care in Bangladesh. I think, and once anyway, I think um, we're doing small steps, but there's some movements, but not enough in 2025. Bangladesh, I think, one of the few countries that still doesn't have an official recognition of emergency medicine, EMS, and at least there are some basic care, but not ideal care in the community in the remote villages. Um, I think we are nearly there. I think I have one or two last questions, then we'll have to wrap up. I haven't seen anyone, and there are a few audience, but anyway, they're probably more listening than contributing. But I think it will be recorded, and then the others for later to have a look. Two things. I think you said you've been involved in Cox's Bazar.
Mm-hmm.
What did you done? What have you done in Cox's Bazar?
Yeah. Mostly in Cox's Bazar, I did it started out first, I was providing direct medical care, like primary care, in one of the Rohingya camp clinics. That was with Med Global. And that then branched out to, I implemented and created a program to train midwives and OBs in basic obstetric emergencies. And I was not the trainer there because I'm not an obstetrician, but we brought in obstetricians and we taught about the basic life support in obstetrics. And then we also did obstetric ultrasound. So very, very basic point of care obstetric ultrasound. I brought in a team to do that as well. And those programs are still ongoing, which I'm very proud of the Bangladesh team from Med Global. They did an amazing job. They championed all of those programs and moved them forward. And my favorite thing is to become irrelevant. I love when that happens. It means that I did my job and get to hand everything off, which is great. And so yeah, they continue forward with that. They were able to train several women midwives and obstetricians, which is incredible. And this is big because and the reason I was always so excited about it is because of the fact that training midwives is not something that everybody wants to do because there's a concern that midwives aren't doctors, but truly they are the ones delivering the babies. And it's crucially important to give them as many of the resources as necessary for safe delivery, safe AMC care, and things like that. So that was a really big motivation for me to do that. And I'm really excited about the fact that the obstetric society in Bangladesh was extremely excited about this as well. And so which again kind of goes back to people in Bangladesh championing this idea and moving it forward. And I was very excited to be a part of that in the early phase. And so yeah, those were the main things I was doing in Cox's Bazar. And then of course always teaching and things like that. We had on the topic of community training, I did a class with the Rohingya community about what are some of the danger signs, meaning, when do you need to seek medical attention? I think one of the things we see all the time in countries like Bangladesh, whether it's the Rohingya community or the host Bangladesh community, is that people often don't know when to seek medical care. And so, talking about what are some of the danger signs. At that particular time, I think it was rainy season, and so we were talking about diarrheal disease and things like that. So, that was a really interesting experience, and the work that I did in Cox's Bazar spanned probably the course of 5 or 6 years. So I have a very special place in my heart for Cox's Bazar and the whole team there.
Wow, wow, amazing. So you said it started as a Med Global program, but is it still Med Global or is it locally run now?
So the Med Global team is all local. So it is technically locally run in the sense that Med Global Bangladesh is running those programs, and it's all Bangladeshi staff. And so that's the best part. They have their own connection to the community there, which is great. And so that's being run by them, and I think it's still being overseen by the Med Global headquarters, but the local team, the national team, is running all of that, which is excellent. They're incredible, and I'm so glad to see that the work is still going well.
Amazing, amazing. Right. Again, we actually crossed the time limit, but anyway, I don't mind to move a bit more. Um, what's your future vision for Bangladesh?
Oh, the future vision for Bangladesh, I mean, I think at the base is that, access to high quality healthcare for everyone, not just for the wealthy. Bangladesh has a history of having a giant wealth gap, and I think that's changing as Bangladesh evolves. And I would love to see that high quality healthcare is available to everybody at a cost that is feasible. And then secondly, I would love to see innovation in Bangladeshi healthcare, and the reason for that is because Bangladesh is and has so many innovators because of the need for that, right? Like it's the country that grew and in the history of so many other countries is rather young still, and the amount of innovation that you see coming out of Bangladesh, especially the youth, is pretty incredible. I'm like so excited about that, and I would love to see how that kind of translates into the healthcare system because it's a mass of 160 million plus people. Without innovation, how do you provide healthcare for such a large population? So I would love to see innovation in healthcare, and then lastly, I would love to see the absence of politics in healthcare. I believe very fiercely across the globe that politics has no place in healthcare, that the lives of human beings should not be politicized, and how we provide healthcare should not be politicized. It should be a standard. No matter who is in charge of the government, the healthcare and quality of healthcare should always be equitable and accessible. And I'm hoping for a future where that's possible.
Wonderful. Wow. You have very unique vision, and I believe some of them should be, we are that way. We're moving up, and I hope that we will see a lot of changes. I'm hoping in the future. And obviously, Naren, it was really lovely to have you today, and I believe we have to reinvite you in the future for further sessions on specific topics. It is a generic topic anyway. Um, do you have any advice for doctors who are pursuing this career in emergency medicine and critical care in general?
Um, oh, let's see. I think my advice would be, um, I've been doing critical care for nearly 14 years now, and I would say that the burnout of caring for critically ill patients is a very real thing, whether you're in the emergency room or the ICU. And I would strongly advise that people focus on their own mental health. As a healthcare worker, it's crucial. Nobody else will focus on it except for you. Unfortunately, that is the reality that we live in, and so I would strongly recommend. I know it's not the typical advice that people would give, but I think for me, the typical advice is work hard, you'll get where you want to get. But I think from my end, my advice at this point in my career would be really focus on your mental health and the balance. It's important to have balance in life, and what we do is it's an important job. I'm so privileged and proud to be in the healthcare profession, but I also think that it's an important thing to remember that there needs to be balance, or we cannot continue to do the work that we do. So that's probably the advice I would give.
Absolutely, absolutely. This is actually, I agree, completely agree with you. We are pushing sometimes too much ourselves, even myself, and not thinking about my own well-being. And actually, to be honest, we need to look after our own well-being. This is absolutely true. Nobody else will unless we don't. And that's crucial because you need to be stay healthy and focused, and with a lot of energy to help other people, not just you know do something and you die. And anyway, that's the things. I think today we a bit of overdrive, and it's 15:17 today. So thanks everyone today for coming and joining. We had a general discussion. We are all fortunate to have Dr. Nareen with us, giving us a bit of insight into emergency medicine, emergency care in Bangladesh and globally, and her unique journey towards where she is now. And I really think we're really honored, Narin, and would love to invite you again on different agendas, on different topics. And I would love to, I would say, all the other doctors, I would think we need to use you as a resource to help Bangladesh moving forward. I don't think many people know you. Just why I invited you today, so that other people know that you exist. So now we know that you exist, and now we know that you have a lot of skills and knowledge. I think we can use you moving things forward, and actually help Bangladeshi people, and to make the future dreams come true, and healthcare for everyone at the same level. Any last word, and then we will.
Yeah, no, I just thank you, and of course, any way that I can help move the needle forward, I'm always here as a resource, and just encourage as much local leadership as possible, and always here to support that.
All right. Thank you again so much. I'm gonna close this meeting today. Thank you, guys.